Today, Kurt is going to talk to us about all of the little nuances of buprenorphine, all sorts of facts.
Fascinating facts.
I'm giving these announcements.
Okay.
So, announcements. So, free CME, the small print we have to put there. Yes, these are recorded. We already had that moment of stating that. Please turn your video on in case you forgot how to do that. There's a nice little depiction. And if there's multiple people in your room, please chat us in. Let us know who's all there so we can get everybody the credit. Upcoming, this is not a for sure in 2 weeks, but we might be repeating this depending on your all feedback. So if it stinks, just please tell us so we don't do it again.
On Tuesday.
On that Tuesday. So, this is today. So next week we will have Ryan Carroll from HIDA coming on to talk about all these drug trends, like super fascinating and crazy information. And then trafficking, which is god awful. And I met a patient today on that. And then some CBT based pain management. That was Freudian. If you want any help with anything throughout or have any questions about any weird, bizarre cases, I will type Beth's email and phone number into the chat. Just kidding. That's our phone numbers. Please call. Don't hesitate. Email Erin. We are always willing to help with whatever. We now have this.
I'm just kidding.
But you're not. Now you just wasted another 30 seconds.
Yeah.
We now have the site up. So there is a web page or a website, part of the Stratus website, that has all sorts of information on it. So you can click this thing, but you can link to any of the echoes. I'll show you in a second how you can get the case forms, because we all are going to start calling on people to present cases soon. There will be handouts, flyers, anything that we use in our clinics that will be updated. There'll be general information so you can point people in your clinic to it as well as we get those updated. So how do you submit a case? A couple different ways. This was supposed to be updated, but it's not. So you can go to that website I just showed you, or you can use the announcements email, or you can just ask us. But basically you find the attend an echo session, click there. You're not going to click on this one. You're going to click on the SOAR one, and then you're going to hit where it says fill out, save an email form, or just ask us. And next week, Friday, we do have the relief pitcher. I have a son who's actually a really good pitcher. I don't think he quite throws quite fast enough yet. But anyway, we have a free boot camp up in East Grand Forks, or in Grand Forks somewhere next week. Yes, so there'll be CME. It is of no charge. This is how you register for this. No, there is not a hybrid virtual option. Unfortunately, that's just really complicated. It's at this really pretty center, I guess, but it's kind of all of the things in person. More Addiction Connection podcast. Yesterday went xylazine. So your horse tranquilizer and your deer tranquilizer, and how patients are mixing that in with pretty much anything to prolong the effects of their opioids and all of the complications that come from that. But xylazine is now being seen in quite a few overdose deaths in our state, as Dr. Baker said last week from the medical examiner's office. And objectives, you can read. We put these here so then they can be on the evaluation. But
all right,
with that, I will have to turn this over to Kurt, everybody. So major apologies.
Yeah, so finally we're going to have a little fun here. So today we're going to talk a little bit about
the button.
The button. Okay. So we're gonna talk a little bit about just kind of a brief review of buprenorphine, and we've had different talks in the past about buprenorphine that were kind of highly technical. This is going to be a little less technical and a little bit more about some of the interesting parts of it, especially with the ceiling effect, how it interacts with benzos and the risks, and again with testosterone, some of the other different things, how it affects that. So it's kind of a fun talk. I actually put this together a couple of months ago. Been waiting for a chance to give it, and we had somebody rescheduled their talk today. So
chance to give it. Yeah, he still updated it at 9 p.m. last night.
Well, yeah, long story. So first we're going to talk a little bit about the overview. And I think it's a fun thing to kind of know. Really, this was actually developed a long time ago in the 1970s. They were looking at this. And I think that especially Charlie's not here today, but he's really very interested in the narcotic farms that there were back years and years ago. before the 70s, where people went when they had an issue with opioids. They would go to one of the narcotic farms was actually in Lexington, Kentucky, and they were actually trialing this particular drug at the narcotic farms. One of the interesting things about it was also thought to be potentially something to use to treat UTIs because of its unique pharmacology. But it's been around a long time, and so I think that. From our standpoint, we think of this being relatively new because in 2002 it was kind of at that point FDA approved. I remember it was 2002, and that was just the parenteral form was not really approved until in 1989, and they were actually using that for analgesia. So it was not used for anything like opioid use disorder. I think it's also important to understand that it was used abroad quite a bit. And long before we were using it in the US, it was being used over in Europe. And so it was a drug that was well known there. Now, remember that when that 2000 Data Act passed, it allowed waivers for only the sublingual formulations. And at that time, it was actually a Schedule III drug. So it was not in that same category with all of the other opioids. And of course, it was pretty well known at that point that it was not a full-on opioid. Since then, we all know that there's been lots of different things that have popped up other than the sublingual films and tablets. There's now implants, and I don't know that those are FDA approved yet. I have not seen, nobody's come around and said, hey, we can use these things. But of course, the Sublocade, and there's many other different types that are actually in development now that we'll probably be using down the road. Now, buprenorphine, of course, is used because it's associated with positive outcomes. And when we look at some of the studies, especially overseas, where it was used much longer, and they have much longer experience with it. In France, there were studies that showed that if you discontinued your buprenorphine, you were 29 times more likely to die of an overdose. And so it really has been associated with very positive outcomes. And I think from a community standpoint also. So we know that when buprenorphine programs pop up in communities, there's less crime. We have less HIV, less hepatitis C, hepatitis B, all those things decrease. Just a quick review of the pharmacology before we get to the fun stuff. Remember, it's a partial agonist, but it does also bind to delta receptors and kappa opioid receptors. Now, there's not a lot of information really how these particular things how they work or what they might cause. And it's often been thought that the delta and the kappa parts of the pharmacology probably don't really cause much interaction with or cause many different things for us, right? It's likely a minimal effect. Now, the delta and kappa involvement, because of that, it's actually, and some of you may have read these studies, they've actually looked at buprenorphine in the treatment of anxiety and depression. And this has been going on for a while. I think we all know that when people take opioids, that frequently they feel more calm. And often that's why they're taking extras, because they realize if they take it, it actually makes them feel more relaxed. And I think that we spend a lot of time trying to make sure patients understand that this is a very long-acting drug. They don't need to take it. They have to understand that when they're feeling symptoms that they sometimes think are withdrawal, it's actually anxiety, and they're taking extra doses. And just to kind of put this out there again, remember that the affinity for buprenorphine for the mu receptors is very strong. And when we look at even something as simple as oxycodone, it's attracted to that mu receptor 120 times stronger than oxycodone. Many times we're seeing things that mostly fentanyl now. You're looking at maybe 5 or 6 times higher affinity for those mu receptors. So that's why precipitated withdrawal happens, because clearly buprenorphine can push these other medications off the mu receptor really with no difficulty. As far as potency, I think it's important to understand this is a very potent drug. It doesn't have the same effect as some opioids, but it still has a high potency. And really, potency would be described as a dose that's required to cause a given effect. And so when we look at 2 different drugs, if it takes just 10 milligrams for one drug to cause a particular effect and 100 grams of another, that would obviously be a 10 times more potent drug. And so I think when we look at buprenorphine, we have to understand that potency also depends on the efficacy and the affinity that it has for the mu receptor. And if we look at low doses of buprenorphine, we may have some degree, for instance, of respiratory depression compared to morphine, but that potency does not increase with doses in the clinical range. So we're going to talk about this in a little bit about some of the side effects of generally most of the opioids. But when we look at things like the partial opioids like buprenorphine, that we don't get the same effect that we get, but a very potent drug. And remember that the concept of potency is important when we're trying to understand, well, why does buprenorphine, why shouldn't we use the MMEs in some way of kind of tracking it? Because the MMEs for buprenorphine are much different, especially when we look at the opioid analgesic effect or for assessing the risk of OD, right? So when we look at the doses of buprenorphine, even though it's a very potent drug, if we go up with the dosing, we really don't see a significant difference in overdose death. And for that reason, the CDC guidelines don't include buprenorphine in any conversion tables. ASAM doesn't really support legislation limiting buprenorphine based on MMEs, because the MMEs, as far as overdose death, the things that really matter, is not really all that important. So how about buprenorphine dissociation from the mu receptor? Remember, bup really stays attached to the mu receptor for a long time. And of course, this contributes to that whole long duration of action. I think all of us look at buprenorphine as kind of a medication that we should be using every single day. But in fact, there's been many studies that have shown you can use buprenorphine even every other day or 3 times a week. If patients get used to that, they won't get withdrawal symptoms because it is such a long-acting drug. And so really, studies have shown minimal withdrawal and similar rates of drug use compared to daily dosing when they're doing it intermittent.
Can I say something to that? And I don't know if you have a slide on it, but I think to keep in mind, though, patients will often say they feel like they're withdrawing and take the second dose in that day. And a lot of that is that anxiety or that fear, or it's that habit from when they previously were using their other substances. They were used to using it that often. So it's almost that trigger type sensation. So because you can do it this infrequently, helps sometimes explain and reassure the patient.
Yeah. And I spend a lot of time trying to explain to patients that, they can miss a dose and typically they should not feel anything. And often they think they are. And I think often it's that anxiety of missing the dose. And actually, when you look at, studies using dose ranges from 8 to 32 milligrams, withdrawal symptoms were generally mild, increased over time after the last dose, which we've all seen. But interestingly, the severity is not really related to the dose. And I think most of us would have a hard time believing this. But actually, Dr. Heather gave a talk just yesterday, and we talk about neonatal withdrawal syndrome. And when we talk about it with Suboxone, when babies are in the hospital, the studies have shown that it doesn't matter what the dose the mom is on, that the babies don't have significantly higher rates of withdrawal if the mom is on 32 milligrams as opposed to 8. It doesn't make a difference. And so the studies actually show that as well in patients, that the withdrawal is basically the same, depending on no matter what your dose is. And it's really this, I think one of the other things when we look at pharmacokinetics of buprenorphine, remember, there's an enormous variability from patient to patient using the strips or the pills. And really, if you look at the estimates of bioavailability, that amount of the parent drug that reaches the systemic circulation, it can differ up to 3 times from person to person. And so the effect that one person may have or the dose they may need can be vastly different depending on how well they absorb it. I think a lot of times when we see patients, we have a hunch of where they're going to end up based on how much of a substance they might be using. But I think we should also understand that their absorption is a huge part of that. So we shouldn't assume. We should really kind of wait and see what their effect is.
And that can matter to patients too, because they think, well, I shouldn't be on this high a dose. And so trying to explain to them that just because so-and-so is on this dose and you're on this dose it's not apples to apples. Yeah.
So again, the differences are probably a lot of times due to the individual variability of the absorption. If we look at the Sublocade, for instance, and the IV forms of bup, really the bioavailability that's hard for me to say. The bioavailability is actually very high. It's basically 100% when you're doing it IV. But remember, when we've got to absorb this, it can be patient to patient variability can be huge. Remember how it's metabolized too. I think it's important to kind of understand this whole first pass issue, because buprenorphine metabolism, of course, goes to norbuprenorphine, which when we're checking levels of bup, we're always looking to see what their norbuprenorphine level is. And sometimes that can give us a clue. This isn't hard science, but sometimes it can help us know whether or not, based on the ratio, whether a person just took it in the last few hours or they've been taking it regularly. That first pass metabolism in the liver happens really with all the sublingual type medications that we're using. But remember, if we do the injectable, we don't get that. We don't get that first pass. Now, norbuprenorphine is also an active metabolite, although there's a couple different ways that buprenorphine is broken down. There's a glucuronidation as well. And so there can be other metabolites, but those are generally considered inactive. So norbuprenorphine is active and again, can vary depending on how you give it. So these are the fun facts. Remember, although norbuprenorphine is active, it's very low concentrations in the brain. And I think that the thought really is that it may not have a lot to do with the clinical effects that patients get, because although our level in the urine is relatively high, the level in the brain is actually relatively low in comparison. The routes of administration that are affected by that bypass as it goes through the liver are really the IV and sub-Q, right? So those ones go through the liver, and so you're going to get a much lower norbuprenorphine level if they bypass it. So think about if we're doing this sublingual and it goes through, your norbuprenorphine levels will come up very quickly. But if we're giving it IV and you don't get that first pass, it will take a lot longer for the norbuprenorphine levels to go up, and they may always be a little bit low. So if you're checking a level on a patient, just understand that how we give it really tells us what we're going to get for a level of the norbuprenorphine. The liver, let's talk a little bit about the liver, Heather, just in case you wanted to know. And so when we started doing this years ago, there was always this question of whether or not buprenorphine could affect the liver and whether or not we should be checking liver functions. And I think there's been the same questions with naltrexone, okay? Buprenorphine, so this study was done actually in 2013, and it was actually done by NIDA, and they were trying to decide whether or not we even need to screen people for their liver issues and whether or not we could give it to people who had liver function abnormalities. And so they enrolled all these patients who had AST and ALTs that were less than 5 times normal, but they could be up to almost 5 times abnormal, as well as now FOS that could be 3 times normal or below. And so they took this group and they randomized them to methadone or buprenorphine, and they monitored their liver functions after they put them on these meds. And it's very interesting to find that there was no evidence that you affected the liver at all the way up to 32 milligrams of buprenorphine. And so the thought that buprenorphine really affects the liver is probably, you're probably wasting your thinking if you think about this too much. And
when you're hurt and you don't have much thinking power, you don't want to waste it.
No, I'm not wasting one moment of that. And so really, if you ended up with increases, in this study, most of those were found to be actually seroconversion from Hep B to Hep C or other illegal drug use. Something else was in their urine that was causing that. So just understand that for the most part, we don't have to worry about the liver with buprenorphine. It really doesn't change much. And I think that let's talk about buprenorphine when you mix it with the naloxone products, because we also get a lot of questions about the naloxone that is in the buprenorphine. And if you look at this, remember naloxone, of course, is an antagonist, a full antagonist, and it's got a very strong affinity for the mu receptor. But typically it's very inert. It's mostly, when we put this in the oral and sublingual preparations, it doesn't do much because it's destroyed by the GI tract. In fact, it's thought that the bioavailability is probably 3% or less. So it's not enough to give the patient any symptoms, even if they swallowed the pill. But if you give naloxone IV, of course, that's 100% bioavailable. And if you snort it, it's about 30% bioavailable. So again, in the oral preparations, it's really not much of an issue. When we look at the sublingual and transmucosal overview, basically, I think the thing to remember is that this safety is really well established. This is a very safe drug. The side effects are similar to other, receptor opioid products. It's not much different. We still get the constipation. We can still get these other things. But the bioavailability can be variable. And it's important that we understand if people are still having symptoms or cravings, even though if we think their dose should be enough, maybe for that particular patient, it may not be. Other aspects of these products are largely comparable. And, I was going to mention here on the slide before, I just mentioned naloxone. And I think the other thing when we see patients, we're going to start them on MAT. If you're thinking about naltrexone or Vivitrol, there has been that whole thing, do we need to check their liver functions for them as well? And actually in 2016, I believe it was NIDA and ASAM both came out with statements that studies had shown that really that was probably unnecessary unless they had some significant other liver disease, that for the most part, it is not going to increase your liver function abnormalities. So are there differences in these transmucosal products? That's another thing you have to really think about. And the answer is yes. Changing formulations, I think a lot of us have seen this, is that when you go from a one that's the name brand, and then suddenly you drop and you change them to a generic, suddenly they go into withdrawal. And we've had breakouts, if you will, where all of a sudden we had withdrawal breakouts in town where
not like major withdrawal.
Yeah, like 3-4 patients calling and saying, my God, I feel like I'm in withdrawal, and they all changed to a different formulation. So there is a big difference. There are actually comparison tables of bioavailability for all the different formulations. And it was in one of the papers that I reviewed for this. So you can actually look at that, and it shows the different plasma concentrations depending on what medication people are taking. If you look at the implantables, which we have not ever done in our clinic, these are actually interesting. They're much like some of the other different products we've used that are subdermal. It's interesting because if you do start using these, they're actually made for people who probably require 8 milligrams of sublingual buprenorphine or less. It's a very similar plasma concentration. They use these for about a year. In my mind, when I review this stuff, to me, this is a patient probably that has been on bup for a while, it's been tapered down, and doesn't want to take the medication every day. And this might be an easy way to keep them on. They've actually been shown to be very helpful, that they are very efficacious. And in fact, studies show 81% of illicit drug abstinence compared to sublingual, which is probably closer to 70. So they do work. They are on board all the time. I think not much different than Sublocade, probably about the same price.
Have they talked about the at all how many you can continue doing then? Because if it's only good for a year, well, then what?
Yeah, it's interesting because some of the stuff now, they just say that it should only be used for a year.
But then what happens after that?
Yeah, they don't say that. And I think it would be considered off-label if you just kept going.
Right. So I think for me, I think it's a great option. Like if someone has to go do a prison or jail sentence for a period of time.
Yeah, that would be great.
That would save a lot of financial issues, but then what? Yeah, then what?
So I'm going to talk about Sublocade just to make one point, actually, and this in some of the literature that's come out fairly recently. This was FDA approved in 2017, and I think most of us know the dosing of this, that you generally start with 300 milligrams, then drop to the 100. With fentanyl, there has been some concern that dropping to 100 is going to cause problems. And that if people were IV drug users, and all the IV people that we see are fentanyl, that you may want to consider going to 2 months of the 300 milligram injections before you drop down. And it's probably going to be a little more effective. So I think that's just something to kind of keep in mind. So just understand, buprenorphine is unique in its pharmacology and pharmacokinetics, and there's many formulations available. We just got to kind of tailor it to the patient. And I think that, and then our patients will get their best care. So let's talk a little about the ceiling effect. And I just got a short little blurb on the ceiling effect, because one of the questions we get all the time, when we get questions or calls, and I think probably one of the most common calls that we get is if somebody has been off off the heroin or fentanyl for a while, and they did it on an abstinence-based way. Well, when we start their buprenorphine, how slowly or how quickly do we go up? And I think people often think we have to go very slowly from a risk standpoint. And so I really wanted to find some information that would be helpful for people. And so this is actually, there was a study that was done not long ago. It was actually one of the first studies that demonstrated kind of the ceiling effect of buprenorphine. It was done a few years back. And they did something really interesting. They took these 16 healthy males who had opioid history, but were not currently using any substances. So they were abstinence-based, and they brought them into this study to really look at the ceiling effect and the side effects of buprenorphine at particular doses.
Did you ask Katie how long it took her to find a picture of 16 males?
I have no idea.
Did you get permission to use this photo?
I have no idea. So anyway, so here's what they did. So they gave patients one dose a week. And what they basically did was, is that they doubled the dose every week to see how patients would respond to it. So as you can see, they started the first time with the placebo, they gave them 0, and then they checked them for all these symptoms that they might expect with buprenorphine. Then they went to 1, 2, 4, 8, 16, and all the way to 32. And remember, these doses are a week apart, and then they would monitor these patients after the dose to see what kind of symptoms they might have.
Just wait a second, I gotta close this.
Okay.
Okay.
And so, and I think it's important when you understand, when we had some of the talk about potency and all, if you take 32 milligrams of buprenorphine, that would equal 530 milligrams of morphine or over 1,000 milligrams of methadone. Now, either of these doses would be in the normal person, these would be lethal. But 32 milligrams of buprenorphine, I think, as we all would assume, is probably not, or they wouldn't have done this study. And what they found was that buprenorphine was actually tolerated at all of these doses in patients that had no opioid tolerance. And there were no significant changes related to their respiratory depression. These patients had no symptoms of concern at all. And so when I look at patients that are naive, and I'm trying to get them on buprenorphine because they're having a lot of cravings and they're a few months out from using opioids, I will go up relatively quickly. And I don't worry about causing respiratory depression because for the most part, that's not going to happen. So be comfortable going up quickly, get the patient safe. And I think that don't worry that you're going to cause side effects. You don't have to wait a week before you change doses. So lastly, we're going to talk a little bit about some of the issues with buprenorphine, methadone, and testosterone. Now, one of the things that we need to consider is that, we think about what has been shown with long-term opioids for pain. And there's been a very big study, one done by the VA probably 5 or 6 years ago that came out that showed that the reality was anybody who's on long-term opioids should be having their testosterones checked. Why? Because their testosterones almost routinely drop to the bottom. And it's very common. And in fact, if you replace their testosterone, these patients have increased all-cause mortality, if not replaced, right? So they have shown that if you replace their testosterone, these patients live longer, bottom line. And that's with regular opioids. So the question is, well, how does buprenorphine kind of play into that? So, if you look at hypogonadism and low testosterone, levels as a side effect of methadone and buprenorphine, this study was actually done in 2012 in just a letter to the editor where somebody kind of said, hey, here's what I'm seeing with these medications. And he pointed out that at the time we already knew that, that opioids caused this problem, that these low testosterones were very common with most long-term opioids. Methadone, of course, had been around a long time, and there was pretty clear evidence that methadone also fell into that same group. But there was really no info when he sent this in, and this was in 2012. He was trying to find information about buprenorphine and whether or not we had to worry about people's testosterones with the buprenorphine. There had been previous clinical studies, a couple different ones, where they showed that methadone patients had a very high prevalence of erectile dysfunction. It was a small sample size. And again, in 2009, there was a guy, Hallinan et al., showed that patients on bup had significantly higher testosterone levels and less erectile dysfunction than methadone across the board. But this was, again, a very small sample size, no pun intended. So here's one of the first studies that was done with this. They actually were looking at buprenorphine, methadone, and testosterones, and this was actually done by Yi et al. And this was in the Journal of Sexual Medicine. And they did kind of an interesting thing in these Eastern Asian men. They took 107 married men. They recruited these guys, and 71% of them were actually on methadone and 29% on buprenorphine. And they were all about the same age, right in the early 40s. And they were going to look and see whether or not sexual function was really different and testosterone was really different. And the results of the study were very clear that total testosterone was lower in methadone patients than buprenorphine patients. And actually 40% of the men who were on methadone were found to have significantly suppressed testosterones. It's not to say that you can't get this with buprenorphine, and I've actually started testing some of my patients, my male patients, with their testosterones if they have any symptoms at all, because they do need replacement. But only 20% of those on buprenorphine had those lower testosterones. And I think that still that's 1 in 5, and it's probably worth checking if there's any concerns. These findings actually were consistent with some other studies that have been coming out. But overall, I think methadone, if you have patients who are on methadone or any other opioid, they should be tested yearly, and they should be replaced if they're low. It's interesting because one of the things that he talked about in this study was that there's this theory that buprenorphine kind of antagonizes the kappa opioid receptor, and that may somehow kind of block this depressive effect at the mu receptor kind of along that gonadal axis. So there's this kind of thought that maybe it's a kappa receptor that has something to do with our testosterone levels in these patients being a little bit low. And in fact, they've shown this in rats, not that we can absolutely move this on to most humans. But again, in rats, methadone really exerted that effect on male reproductive organs and kind of blocks this gonadotropin releasing hormone. And so they really surmised at that point that it causes that decrease in serum LH. And of course, that just results in decreased testosterone production. So interestingly, in the rat studies, they did not find the same issue in rats getting buprenorphine. So I think that's something to understand is in rats, it may not show up, but I think again, in men on buprenorphine, still probably 1 in 5 has been kind of the number that's been thrown around. So the summary of this is that, again, methadone associated with sexual dysfunction and lower serum testosterone, whereas buprenorphine is much less likely, but not impossible, to cause that same thing. All right, I'm trying to move the slides, but my assistant, oh, hold on, I can't call her.
Don't you dare.
Okay, so now we're going to talk about benzodiazepines, because this is also a question that we get a lot, is like, can we be on benzodiazepines and Suboxone at the same time? Early on, when we were doing this, we really avoided it. And I'll tell you, I think there were patients that showed up on it, and I think often we don't know exactly what to do. So we're going to try and help that. I think some of the studies here are really pretty interesting. So one of the first studies actually was using benzos with buprenorphine treatment, and especially when they're in for opioid use disorder and clinical safety. And this was actually done over 10 years ago. And really what Oliver et al. Were doing is they were trying to decide, what's the retention when patients are on benzos and buprenorphine? What happens to their urines when they're on both of these? Are they better or worse? And how does benzos affect emergency room visits for patients who have opioid use disorder? And how many visits do we get with patients who are ODing or have an injury? And they actually did a retrospective study of 328 patients to kind of look at what happened to patients who were dually on bup and benzos. And what they found was that if you looked at the 12-month retention when they were on both, it was about 40%, which I think is interesting because when we talk about retention rates, typically for Suboxone, I think we tend to look at it right around 60% as kind of the national average. And so it's interesting in this study, that was actually a little bit less. Benzodiazepine misuse nor benzodiazepine prescription use was related to retention or illicit opioid use. So it really didn't play into it much. And in fact, what they found that was so interesting was that benzos were associated with 73 times higher risk of accidental injury for those patients who are on a benzo with their bupe. And in fact, it was 4 times higher in women. And then we always think that men are so clumsy, but in the women on benzos actually had much more issues with injury than men. What they also found was that there was a slightly lower risk if patients were on long-acting benzos as opposed to the shorter actings. So they really felt like we should be avoiding anything that's relatively fast-acting, that their risk of injury and other OD was actually lower. And if they looked at the risk of Z drugs such as Ambien and other sleepers, that risk was lower, much lower than the benzodiazepines. Again, this is something that we run into. We got patients that are showing up and they're on Suboxone, or they want to be put on Suboxone and they're already on a sleeping pill. And I think we always have those concerns about respiratory depression and other things. So really their recommendation at the end of this paper was really to say, we should be switching patients to long-acting benzos if they absolutely need them, or a Z drug. We should not be using benzos for sleep was really one of the things that they talked about.
I wouldn't remember, like, don't use a Z drug until you've done a sleep study.
And don't use a Z drug. That's a good point, until you've done a sleep study. But Z drugs are potentially safer from that standpoint. So then there was another study that came out just in the last couple of years, and I can't say this guy's name. We'll just call him Dr. X, Zhu. But he did a little study on association between the benzos and Z drug prescriptions and drug-related poisonings, basically overdoses, among patients receiving buprenorphine, okay? And it's interesting what he did. They found that as they got going, they found that 30% of their patients in this study actually that had opioid use disorder were on benzodiazepines. And Dr. Heather and I were talking about this just a minute ago, because I think between us, we have 2, and there's probably well over 100 patients. So we're far below what they were seeing in this study as far as patients on benzos. And again, Z drugs would be things like Ambien, Lunesta, all of the different sleeping pills that are related, but not exactly the same as benzodiazepine.
So like your Zolpidem, let's use the generic.
Yeah, Zolpidem, yeah. And interesting, if they looked at this group, about a third of these patients were clearly misusing their medications. Now, what was unclear was whether the risk of the benzodiazepines and giving them buprenorphine outweighed the benefits, right? So this is the question they're trying to answer is there higher or lower risk when somebody's on a benzo when they're also on buprenorphine? So what they first found was, and this is different than the other study, was that the retention seemed to be better when patients were on benzodiazepines. So patients in their study actually stuck with treatment better if they were also being prescribed a benzodiazepine. So I think that's pretty interesting when the patients, and these are patients that are in an outpatient treatment. But again, the benzos, just like they were related to accidents and overdoses, they found that the benzos were related to many overdoses or poisonings as well.
So were those prescribed benzos in
Correct.
that study?
These are prescribed benzos. Mm-hmm. And so they had some concerns with this study. And one of them was that when they looked at the study, patients were on many different types of benzodiazepines. So these had different half-lives, potencies, and so on. And they didn't really study that, the morbidity and mortality associated with the differences between them. So they wanted to make sure that people understood that they were just taking all benzos as one big group, whereas the other study really looked at the fact that the long-acting seemed to have less risk. There was very little research, if any, on drug-related poisonings with things like Ambien, or Zolpidem, and other medications. So I think that's still something that's out there. And again, this study was just done a couple of years ago, so I still haven't seen much else. And basically, what they said is there's a huge research gap, right? We'd have no idea what the outcomes would be in these patients with OUD that are taking bupe and a benzo and a Z drug. We just know that there is clearly some increased risk in some of the early studies. He did a follow-up study, actually, and he looked at the same guy, Dr. X here, and he analyzed non-fatal overdose poisonings associated with specific benzos, right? He did that follow-up study that he said was kind of the concern. How do we know which one's better or worse? And they also looked at some of the Z drugs. And it's interesting what they found. The first thing they found when they looked at this is that if you actually took your buprenorphine every day, on the days that you took that, it actually decreased your chance of overdose or poisoning by 40%. So if you actually take your buprenorphine, you did much better. Now think about this, that if you have an injection such as Sublocade, and you would read, the way I would read this is you're probably dropping your risk of overdose death if you're on both of them by 40% because you are taking it every day. And so I think that's one kind of takeaway for me is in patients who are on things like benzos, should these be patients that are also on Sublocade to decrease their risk of poisoning? The other thing that they found is any day that you actually took your benzo or your Z drug actually doubled your poisoning risk. So if you're taking those, the days that you don't take it, you actually have less risk of overdose death. And I think that's pretty obvious. And here's what his conclusion really was, that a benzo and a Z drug plus buprenorphine is much less risk than just a benzo alone. A benzo alone is probably a more concerning thing. And that the buprenorphine dose as well, it didn't matter what dose they were on, didn't change their risk. They did a separate arm of this test and just looked at SSRIs. And in these patients, SSRIs did not change your risk of poisoning or death as well. One of the other things that they came out with was really that there was a very obvious clear dose dependency for overdose risk, right? So the benzodiazepine dosing and the Z drug dosing, if they're at the high levels, and I don't know how many times Heather and I have seen patients on, especially women patients on Zolpidem who are on doses that are not recommended in women, for instance. The higher the dose, the higher the overdose risk in general from the mixture of benzodiazepines and other things. So lower dose and decreased treatment of duration is really their suggestion for any benzo in a patient with buprenorphine who has an OUD. I think this is the last little interesting study. And this was actually something they did with benzos and opioid prescriptions. And I'm just throwing this in there because we talked a little bit about, this is kind of, this is just one little going off to the edge. I saw a squirrel and found this study. And so I just wanted to mention this because I think often in the days of opioid prescribing, people think that high opioid doses are safe. And I think it's important to see the benzos and the opioid prescriptions as well and their mortality. And this was actually just came out this year. It was in the Journal of Addiction Med, done by Mooney et al. And really the purpose of this study was to examine opioids and benzos and the co-prescribing and what's their mortality in a large health system. And this was a massive study that they did in California. And they actually used their PMP there to look at this. And it had 5,200 patients. And as you can see, almost 2,000 with OUD and 3,200 controls. So when you look at this, if you look at the opioid use patients, they were more likely to have other substance use disorders, which we all would expect, right? The best predictor of any use disorder is another use disorder. OUD patients were prescribed higher doses of benzos and opioids than non-opioid use disorder patients. So what that's saying is that if you have a patient in your clinic whose previous diagnosis with an opioid use disorder, and now they're being prescribed opioids for pain, they tend to be on the highest doses, and they also tend to be on a benzo, okay? The average daily dose of both is associated with all-cause mortality increases. So clear far and away, the reason that the state has looked at this particular issue is that if you are on both of these, your all-cause mortality is just higher. It just is. And significant interaction in co-prescribed patients on mortality in non-opioid use disorder patients. So again, even in that group, without an opioid use disorder, all-cause mortality, big problem. One of the other things that I think most people find interesting is that if we look at the opioid use disorder patients and the non-opioid use disorder patients, opioid use disorder patients, they just have a higher all-cause mortality anyway, right? And they are frequently in the records that they reviewed, they have higher doses of benzos prescribed, and they have more physical and mental concerns, which also put them at high risk for depression, anxiety, suicide, all of those things. And really, there's been previous research has also shown that more benzodiazepine prescriptions are given in chronic pain patients, especially at high opioid doses. So the patients on the highest opioid doses tend to more likely have benzos. So I think that, again, take this back when you're looking at patients who are on these. I think it's important. I think just understanding that the use of either of these drugs relates to all-cause mortality, and it's dose dependent. So the bigger the dose, the more likely they are to die or have a poisoning. And benzodiazepine dosing is directly related to all-cause mortality risk. So if somebody says that these things do not cause problems, I think that's something we have to think about. The other thing that factors, and if you think about patients that you've seen, the other factors that are associated with increased mortality is really if patients are self-pay, they're older, and they use alcohol. And that older and alcohol we see tons of in patients on opioids, and they tend to have many significant medical diagnoses. So there's also polypharmacy and other medical issues. So the summary, patients in treatment for opioid use disorder have significant increased risk of injuries. Z drugs less so. Patients on bup have a couple times the risk of overdose if they're on a benzo. So that's something that we always have to think about if they're on both, and make sure always that they have Narcan, honestly. And patients with OUD on benzos have increased all-cause mortality, and it is dose dependent. The more you are on, the more you're likely to die.
So that's a question. Did the study refer to how long the patients were on the benzos, opioids with chronic pain?
Did not. All right, lots of sources, man. You can look through those things at your leisure. Thank you so much. If there's any questions, I'd love to answer them if there are any.
Say, Kurt, I have two questions.
Yeah.
One is just to confirm, and maybe you said it, I think I may have missed it. Bioavailability of sublingual buprenorphine about 30%, right?
It's 3%. Or was it 30? I thought it was
30. The bioavailability of buprenorphine.
Oh, it's 30.
You said 3% was the naloxone.
Yeah.
Yes.
Yep. I'm sorry. Yep.
No, that I missed it completely because I just looked it up and wanted to confirm, because sometimes, and thanks for the affinity table as well. It's just hard to find things. Sometimes it's not as consistent. So thanks for this really nice review. I do have on the summary slide. And so bottom line is increased risk with opioids and benzos. I'm going to leave out the Z drug for just a second, or the Z drugs for a second. And so initially the recommendation was don't or what I'll say what we were doing as practitioners, or what I read and understood was, discomfort with prescribing both, and that we probably shouldn't do it. But then later came out that folks who are prescribed benzos or getting them illicitly are probably at more risk if we don't prescribe something for them from an opioid agonist or partial agonist standpoint. So is your interpretation, or is it different now that you've done this review? And I wonder if mine should be different. I don't know what yours was before the review, I guess, and now after. Have you changed in your prescribing practices?
Yeah, I think that after doing this review, I think I was always really concerned about even putting, for instance, if somebody needed short-term benzos. I think 5 years ago, I kind of worried about that, thinking that we might have more of an issue. But I think for the most part, that's not a huge concern. And I think what surprised me most was that there's more than one study that has shown that retention in Suboxone or buprenorphine programs is actually higher, and that patients stick with it better. And that wasn't just that one study. There was quite a few, which I found surprising.
So I think, we used to put a benzo as like an absolute allergy contraindication in our charts when we started somebody on bup. Definitely don't do that anymore. My one patient I've had on, he's been on benzos pretty much the entire time. He has a great full-time job. He is ironically, oddly enough, has high social anxiety, which if you met him, you'd question that. And so it's very as needed. He himself wants to get off, but he has these moments, but he's very responsible with it. I guess, and he has been one that in the past did buy, benzos off the street, which some might say is like a deal breaker then, but he almost had a fentanyl poisoning with doing that. And so it's, I've done short-term ones for certain patients. It's just having that discussion with them and making sure they're aware. And he's on Klonopin, so it is obviously long acting.
Yeah. And I think the one thing that's kind of opened my eyes is that one study where if they take their bup every day, it decreases their chance of death by 40% of a poisoning or overdose. And so I think if I had somebody who absolutely was on benzos and they were seeing a psych and they had them on a benzo and some other anxiety meds, I'd really push for Sublocade, because if they take another, and benzos, it decreases a bit it makes you a little bit more spontaneous. You might do things you wouldn't normally do. And then if you use and you skip your Suboxone, so I guess that's the one takeaway for me. I looked at that and said, man, I'd probably lean more towards Suboxone in those patients or Sublocade. Yeah.
That's a great question, Sarah. And I'm going to turn that over to the audience. Beth, you might even have a better answer to this, but, Belbuca, Butran, so the buprenorphine products for chronic pain, caution for QT prolongation. I guess I've never seen that. You would think it's the same because they're all buprenorphine products. So yeah, I guess I have not personally seen that, but.
This is interesting too. This from Nadia, it says, an insurance company told me that naloxone is not considered a maintenance medication. Therefore the deductible applies. Has anyone else come across this? I have not, but that is completely wrong. To me, that I look at this medication for a lot of the fentanyl patients, especially the IV patients, as a lifelong med. I think most of those patients will not be off anytime soon, if not ever.
Yeah, Nadia, that's crazy. The greater than $300. I'd
be writing a letter.
We've called insurance companies and
have that chat.
I've had multiple chats.
Yeah, that's really interesting. Other thoughts, Beth? You look like you got a thought.
Well, on the buprenorphine and potential for QTC prolongation, I guess this is from asking a number of individuals, including just yesterday. So if methadone, if the practice or somebody's practice is methadone is, for instance, is not the first drug to stop if you're concerned about multiple drugs that can cause QTC prolongation. That's the first thing. And how often are EKGs checked? Are there needed screening EKGs? That there are a number of folks who don't do screening EKGs unless their verbal screening has indicated a need for that, even with methadone. So family history, syncope, things like that, electrolyte abnormalities, things like that. So, and then if we sort of more generalize that more to a drug like buprenorphine, which I think has less of a chance of QTC prolongation, it seems like obviously there are different reasons for picking each of those meds, but the use of buprenorphine, I wouldn't think would make we wouldn't exclude the use of buprenorphine in the setting I think that's described in the chat. Is that?
Yeah. And there's no recommendation to check an EKG. So I'm pretty confused by that. I've not seen anything about that.
Yeah. I do have one other comment from one of the previous slides about the norbuprenorphine brain levels and urine.
Yeah.
It doesn't feel to me, and it doesn't feel to me like this because I haven't read the article or the multiple articles if you found them. I think that's the biggest thing is it doesn't feel to me like we're talking about apples to apples there.
Yeah. And I don't know. They just basically said that one of the things that the thought was, well, is norbuprenorphine part of the clinical effect? And they didn't think so because they didn't think that they crossed the blood-brain barrier as well.
Right.
That
makes sense to me. But the idea that we say it's low in the brain, which is obviously
the levels are low
in vitro,
rather
than and then comparing that to urine levels. But it makes sense in terms of although I haven't looked at the kinetics for norbuprenorphine. But yeah,
I thought that was really pretty interesting.
Yeah.
it's a metabolite, but the reality is it probably doesn't play into it much because it doesn't get across.
Mhm.
So,
It is interesting.
all right. Other questions? All right. I
don't
guess
know.
that's it.
I do want to point out something in case anybody picks up on this like I do. Every time Kurt talks about an article, he says he as the author. And we had an actual debate about this once, literally during one of our upcoming podcasts, a whole debate about whether you should say he or she. So
If the author,
I have pointed this out. It's just,
all right, I'll work on it.
habit.
If it said Bilden, I'd know it was a she right off. I'd be like, Beth Bilden wrote this, but all right, I'll do better. All right, well, thanks everybody for coming this week. Back next week, should be fun. Thanks, Beth.
Yeah, that was great. Thanks.
Sarah, yes. You must have listened to the Charlie
At all,
podcast. Kurt also likes to say et al.
Yeah.
But you said et al today. You said it correctly. I was going to point that out. So anyway.
I've been tutored.
And it took Charlie tutoring. But Tim, thank you so much I think you just logged off, for writing that. But I think we should do a little bit of at least a podcast on probuphine.
Yeah.
So.
All right.
Thank you, everybody.
All right. Have a good day.
Thank you.